thanks everybody for coming. This is our, I guess, kickoff to a series of implementation science workshops. I'll show, actually, going backwards in our slide deck here. We have two more that are scheduled for this academic year, January 24th. Paul and somebody else, Paul Estabrooks, are going to lead a mini workshop again on theories, models, and frameworks applied to implementation science. So how to select them, how to integrate them, how to actually apply them to different implementation research projects. And then Paul is also going to be part of, if not leading, a discussion about outcomes in implementation research that we will get into a little bit today. But the purpose of today's talk is really a pretty broad overview of implementation science. We'll cover lots of different concepts and kind of just key elements of doing this kind of research. And then our future ones will kind of get more into more depth in specific areas to really help people try to apply this to their own work. So yeah, I'm JD Smith. I am actually sitting here in Department of Population Health Sciences on the first floor, and I direct the Dissemination Implementation Science Core that is new to the CTSI since its renewal in April 2023. And we'll talk a little bit about D&I core services at the very end for folks who are interested in taking advantage of those. And then Jenny will be here after her 9:30 meeting ends and will be co-presenting with me, also in PHS and Associate Director of the Community Collaboration and Engagement Team, or CCET, within the CTSI. So the goals today, I'm really hoping that people just come away with this having a basic understanding and being able to understand the goals of dissemination and implementation science. You'll see me talking a lot about kind of the contrast between the perspective of a D&I scientist and a more clinical researcher. And so some of the content today is intended to really help with that mental paradigm shift in what are we really interested in studying and why are we interested in that. I hope at the end you'll be able to also identify relevant implementation outcomes, implementation strategies, and contextual factors that would be relevant for your own work. And then have a little familiarity with some resources for D&I science at the University of Utah moving forward. I was told after doing many introductions to implementation science, I need a disclaimer slide. So here's my disclaimer slide. This is a lot, especially if you're new to implementation science. So who has taken a course in implementation science? Okay, who has gone to like a little workshop, a presentation, something similar to this? Okay, and who is like, what the heck is this? I think I'm in the wrong classroom, or at least your first time. Okay, we have a couple first timers. Okay, so even if this is not your first time, I'll tell a little anecdote. A really prominent researcher at Emory University, you can try to look him up if you want, attended 3 of my talks. And after the third one, these were months apart. These were all introductions to implementation science. He came up to me and he said, I finally get it. And now does implementation science, 7 or 8 years later, and really does get it. But he said it took 3 times hearing the same material to really like fully get it enough to be like, oh, I'm interested in this and I want to actually, pay attention to this. And he was full professor. So it just takes time to integrate these kind of concepts and then, any jargon, any new field. But this is sometimes quite different from clinical research, epidemiology, some other backgrounds that we might have. So the other thing I want to say is this is enough to make you dangerous. It's probably not enough to like write an R01. So yeah, hopefully that's pretty obvious. But okay, so implementation science is really focused quite a bit on the delivery system. And so one of my favorite quotes from this D&I world is by Dean Fixon and colleagues many years ago now, which is really talking about the importance of the delivery system. So he said, the use of effective interventions without effective implementation strategies is like having a serum without a syringe. The cure is available, but the delivery system is not. So we can all probably think of things in our field that are evidence-based practices, evidence-based interventions, treatments, health promotion strategies, lots of different things that we know work that are not actually out in the real world, right? They're not actually reaching people outside of clinical research studies, outside of university-based research. So the goal is actually to take those things that we discover and move them into practice. So very non-scientific, this is not unscientific, is a really helpful little slide that Jeff Curran, who is of hybrid implementation effectiveness study fame, presented this little teaching tool in a publication in 2019 that basically was just trying to set the stage. What are we trying to do here? So you can think about the intervention, the practice, or the treatment that you want to implement as the thing. Doesn't matter what the thing is. It's an evidence-based thing. And we'll talk about sort of the range of things that you can implement here in a little bit. Efficacy and effectiveness research, which is probably what most of us, were taught or maybe even practice still, it really looks at whether the thing works, right? Does it actually change patient symptoms? Does it improve quality of life? Does it reduce infections? Does it reduce morbidity? Like all those sort of things. We're looking at patient level health outcomes. That's what it means by does it work, okay? Implementation research looks at how best to help and support people and places to actually do the thing. So typically when we do, efficacy research, we're not really thinking too much about like who's going to actually deliver this, how does this fit into the workflows of a typical practice. But once we actually know that something works, then we start thinking about that. And if we're going to move it into those real world practices, we have to figure out ways to support people and those places to actually adopt and integrate these evidence-based practices. So implementation strategies, we'll talk about that a lot today, are the stuff that we do. I love stuff and things, but it couldn't be less specific, but also like exactly accurate at the same time. So the stuff that we do to help people, places do the thing, we do trainings, we help optimize workflows, we monitor fidelity. There's all sorts of different things that we do. We restructure teams, we change financing strategy or financing approaches to make sure that our services are covered. Those are all implementation strategies. I'll talk more about those in a little bit and how they differentiate from the intervention or the thing. But those are pretty important characteristics or distinctions to make as we move through. And then implementation outcomes are very distinct from clinical and service outcomes. And these are really helping us understand how much and how well are people and places doing the thing. Notice how I said people and places doing the thing, not how well patients benefit from the thing. So that is not important, but you'll see that the emphasis is really on the people and places and the implementation itself, less so the intervention effect itself. So this field really kind of came out of a recognition in like the late 90s, early 2000s, that a lot of what we spend money discovering and testing through randomized clinical trials, new devices, new medications, new behavioral interventions, that they never actually leave research space, right? So, 30 years ago, practice of translational research often was intervention developers create something, they test it, they publish their paper, they say, okay, it's disseminated, and they move on to the next thing. We all know what happens to most of our journal articles, so those are no different. They don't really go anywhere. Like the uptake just from publishing papers and not paying attention to all the potential end users and systems that have to actually adopt the things that we create is one of the reasons that we have had this gap between, sometimes called knowledge and practice, sometimes called the no-do gap, like what we know works is not exactly what we're doing. And then the Institute of Medicine in 2001 came out with a report essentially on the quality of healthcare services. And what they said was essentially we have, rather than a gap, we have a research to practice chasm. This is my attempt at a joke. You'll see a few attempts at a joke in this presentation. It's an oldie but a goodie. Guy standing, staring over the Grand Canyon saying, well, the gap doesn't look quite this wide in the conceptual model. But essentially, this is trying to illustrate like how far, like you look at a conceptual model of translational research and you're like, oh, this step, this step, this step. The actual amount of effort, work, time that goes into moving from, we know this works, we published our paper in JAMA, now let's actually get it to every hospital, every public health system, every clinic that could use this, is a tremendous amount of work. And honestly, we still don't know that much about how to make it happen effectively. But that is what this science is about. So I have two questions that I want to ask that is related to a publication from 1998 that we often cite in this field, which was about how long it takes to move things into practice. So does anyone want to venture a guess for that first question? How many years on average does it take to move effective interventions, effective things, into real world practice, right? So outside the context of a project, a research study, et cetera. Everyone knows the answer. Okay. So Too often cited, apparently. So the one that's actually like, I think I think honestly has been a little bit of an overblown statistic. Like actually getting into this work and understanding what it takes to change practice, 17 years actually makes some sense. It's still not good, and we do need to be working to try to reduce that gap. But the part that's actually the one more important statistic from this review is the second one. Does anybody know or want to take a guess at the percentage of interventions that actually reach the intended population? So 17 years on average, but not everything makes it. What percent makes it? Paul cheats. Yeah, so your 10% was great. 14% is what this review found. More recent reviews, there was one that was done in cancer prevention and control that looked just at those kinds of interventions. That was just under 15 years for those to reach the real world, and closer to 40% actually did. So we are making some progress in this. And of course, there are some field specific variation that I'm sure exists too. But that is either way, both of those things are kind of disheartening and, challenges that I think we're all up to trying to take on. So let's just do a little bit of brief terminology about what we're referring to when we talk about these different terms. So we often interchangeably use the terms implementation science and implementation research. They are not the same thing. People sometimes say implementation science research, which makes me bristle, but I understand that like there's an Office of Behavioral and Social Science Research at the NIH, so you can't be too picky about it. Either way, so implementation science is technically defined as the field that studies methods to promote integration of research findings and evidence into healthcare policy and practice. So this is a field of science, a field of study with a particular type of focus. Implementation research is basically what implementation scientists do, right? It is actual evaluation and testing of implementation strategies, again, aimed at integrating interventions into real world settings to improve patient outcomes. So we're moving from like knowledge, research findings, et cetera, as kind of big picture to implementation research is a specific intervention with specific strategies, and we are evaluating the process and outcomes of that. So yeah, implementation scientists do implementation research. And then dissemination research, which we won't talk a lot about today, but it is often the forgotten side of the DNI acronym, which is dissemination research. So similar, dissemination science is essentially the study of dissemination strategies and dissemination methods. Dissemination research is the study of targeted distribution of information and intervention materials to specific public health, clinical practice, or policy audiences. So essentially, how do you get information about what we know works best into the people that make decisions about what to fund, what to actually implement within their own systems, what to endorse. This also goes into like clinical practice guidelines, task force, best practice recommendations. All those kind of people have an influence on the dissemination of research into evidence-based practice. Any questions about anything we've talked about so far? Everyone's following and no one will ever say implementation science research. Okay, great. Okay, so everyone, or at least most people, have probably seen some variation of the traditional translational research pipeline. So I show this just to give you a sense of, in the whole world and spectrum of the kind of medical and healthcare research that we're probably doing, where does implementation science fit? And not surprisingly, it is sort of at the end. So for folks who are familiar with like the T stages of translational research, we are T4 or T6, depending on which model you're looking at, but we are far down the translational pipeline. So, a lot of folks do pre-intervention work, which is really epidemiology and really understanding like the causes and prevalence of diseases. Once we actually understand what causes and what is, what kind of is underlying, what kind of mechanisms are going on with disease, we could actually design interventions and test those and see if they work. This was that first part of that efficacy and effectiveness research. So this is efficacy studies. This is basically tightly controlled studies. Can we actually change the thing we think we are targeting with this intervention? If we can, we've essentially got a proof of concept. We do a large randomized trial. We say, yes, this intervention is efficacious for a particular target. So then we move into effectiveness research, which is really trying to ask or answer the question of, does this program work? So outside of the hands of highly trained, highly skilled, highly monitored, highly paid individuals who do most clinical trials in medical schools like ours and other places. Can we actually move this into the hands of more typical practitioners or service delivery agents in their systems? So obviously working within this particular context, and does it still work? Okay. So in practice, we often make distinctions about, efficacy is like, very tightly controlled inclusion criteria, exclusion criteria. We really are honing in on just people who have this one thing, no comorbidities, et cetera. We may have age restrictions, all sorts of things. In efficacy or effectiveness studies, we are sort of taking a bit more of a pragmatic approach. So you may not have quite so strict of inclusion criteria. You may not have so much oversight into how the intervention is delivered, but you're still, looking to see if, again, does this program actually work when we put it into a real system? If it does, you can start to think about making a program work. So we could have changed this into a question of how do you make the program work? How do you support people to best, to deliver this thing? But essentially, this is where implementation science starts. Let me see if I can get rid of those little things. Can't see hardly anything. Okay, it's not going to work. So anyway, let me just go back. So this cube up on the right hand or top right there, the top actually says implementation research behind the top bar there. Let me see if I can get rid of that. Okay, that might actually be okay to get rid of. Nope, does not want to let me do it. Doesn't matter. It's like not on the right screen, and my mouse is like in a layer or something. But anyway, so this cube is essentially trying to show the continuums within this area of research. The front being implementation practice, right? So these are practitioners who implement, or people who practice implementing evidence-based interventions, clinicians, teachers, folks who work at community-based organizations. These are all implementers who practice implementation, essentially. On the backside of that, as I mentioned, it's implementation research. So that is, conducting research on implementation, evaluating its outcomes, et cetera, typically with some kind of a study design that can help you contribute to generalizable knowledge. So that is our right-hand side. Is essentially findings from implementation practice or lessons learned are sort of generalizing or generating local knowledge, right? There are solutions that work for my clinic. I don't know, and I don't necessarily care if they work for a different clinic. I have a particular problem. I'm going to try to fix it. Implementation research tries to ask more generalizable questions. And then, of course, use those study designs as well. But they're really trying to generate solutions for similar clinics, for similar problems that you could be doing. And then in our other dimension here of the cube, we have stages of implementation. So what we see here is what's called the EPIS framework or process model, where we start with a period of exploration. This is really trying to understand what is the nature of our organization's problem, or if you're a researcher, what is a general problem that's happening in the field that we could potentially look for a solution to. So this may be that, I do some work in pediatric hypertension. It only has a 4% population prevalence, but the number of kids who have pediatric hypertension who ever get a diagnosis is less than 25%. So it's a horribly underdiagnosed and, of course, then undertreated condition. So knowing those statistics, we could say, okay, well, how do we actually improve accurate identification and treatment of kids with pediatric hypertension? So that process of exploration is really identifying a problem, identifying where the problem could best be solved, which in this example was pediatric primary care, because that's where most kids get their first blood pressures taken and where any signs of trouble are identified. The solution potentially is better adherence to the clinical practice guidelines. There's been studies that have been shown that if you adhere to the guidelines, you're more likely to accurately diagnose kids with hypertension. So then we start to prepare, right? We have a context, we have a problem, we have a potential solution. Preparation is like, we've made a choice. We're going to try to improve guideline adherent hypertension for kids in pediatric primary care. Let's figure out how to do it. So we pick our implementation strategies. Once we actually enact our plan and start to enroll kids or, have them be affected by this new initiative, that is the implementation phase. After a period of time, this is one of those debated topics in the field, typically about a year, you start to think about sustainment, right? So after a year of implementation, you should have enough data to say this is working. If it's working, how do we keep it going, right? So we often don't want to have implementation strategies that are too onerous or too expensive to continue. But sometimes we do that and then figure out sort of in our sustainment planning, what can we take away without actually, decreasing the effectiveness of this implementation approach. It's not entirely a sequential process. Of course, there is some return to previous stages because there's activities that happen in different ones, but that's a topic for a different conversation. Just kind of think about that's the typical sort of linear process that does happen when it does. So a couple of special cases too. I have this little thing in here because we are now starting to do what are called hybrid effectiveness implementation studies, which is combining research questions, study designs, and outcomes that are both gathering evidence about the effectiveness of the intervention at the same time that we are studying its implementation and trying to understand how to sustain it and keep it going. So that is probably a topic for a future talk or a workshop. But hybrid studies are pretty common in the implementation literature now. So one question that I often get is, anybody been thinking, where does quality improvement fit in? No one wants to admit it. Okay, good. You're learning already. So quality improvement essentially is here. So QI projects, again, are typically trying to find a solution to a local problem, right? It's a clinic that says, hey, we, for some reason, are not doing X, or our patients who have this are not, they keep coming back in and getting readmitted. What's going on? And you dissect the problem, you propose a solution, you implement it, you track it for a short period of time. If it works, you keep doing it. But it's a local solution, right? I don't have any idea, and you don't care at that point either if that's going to work for the clinic down the street. You're just trying to solve your own problem. So nothing wrong with QI. We actually like this bidirectional relationship between QI and implementation research is really important. The stuff that is learned through QI feeds up to potential generalizable solutions. And of course, we hope that generalizable solutions can be adopted and applied in local context and sort of a QI capacity in a way that's going to solve your local problem too. So there really needs to be a bidirectional relationship, but I do just want to make the distinction that QI overlaps with, but is not analogous with implementation research. Question? Yeah, Mike.
Your definitions of implementation science and implementation research, there was like a policy component.
Yeah.
Where does that fit into this? Is it the sustainment part or a full separate?
It could be all of it. So that's probably another topic for discussion. No, I mean, it's a great question. So I'm going to not get all four of them, but there's a really great paper that came out about a year and a half ago that talked about where does policy fit into implementation science. And there was 4 ways. I'm not going to remember them all, but basically it's like one thing you can do is implement policies, right? You can study how do we actually get policies implemented, period. The other thing is you can look at how policies influence implementation, right? Basically as a determinant, contextual factor. So if we have a policy that supports delivery of something, it's a facilitator. If there's other policies that potentially are going to get in the way of or be a barrier, that's basically one way of looking at policy. The other way is looking at policy as an implementation strategy. So how can you leverage parts of policies as a strategy to improve implementation? So yeah, there's kind of a complex relationship, but yeah, it's definitely considered throughout the entirety of this. But it really depends on, is this an issue of we're trying to implement a policy, or are we trying to use policy in some way to help our effort? Does that help?
Yeah.
Cool. Yeah, Dan.
Right, so let's say that your intervention requires knowledge translation.
Yeah.
So at what point, if at all, is it considered in this ecosystem?
Yeah, so I mean, really, dissemination science can start as early as the findings of efficacy studies, and you can start to disseminate to certain kinds of people. I think dissemination tends to ramp up the further you get because you have more and more evidence that this thing is going to work. We also have a unique situation that is not very often talked about, which is the dissemination of implementation research findings, which essentially is all that blue box. Once you learn things that work, how do we let practices and systems and states know that this is working in one place versus, so that they can actually adopt similar things? So it's both levels of the intervention and the implementation strategies that have to be disseminated. But true dissemination research, like just basically like the findings of research and knowledge, that can happen very early. And then it really should continue throughout and sort of ramp up with more evidence, and especially more like just pragmatic, practical evidence. Like that dissemination should ramp up to more people. You're just adding more constituents and more potential like partners and stuff that would be interested in the findings. Any other questions about this piece? Okay. So I mentioned before this whole paradigm shift. We published a figure that was inspired by Hendrix Brown, who was my mentor and center director at Northwestern, and have gotten really good feedback about this. So I continue to put it in my presentations. So in effectiveness research, again, sort of after we've moved out of the laboratory, we are still testing interventions to see if they work, right? Does this program work sort of under more realistic circumstances? So at the foreground, and you'll see this, of course, if you've written or read any effectiveness research studies, your still primary outcome is going to be patient health outcomes, right? It's going to be reduction of symptoms, improved functioning, improved quality of life, reduction of infections, whatever you basically, study. It's going to be here. The dirty little secret of all effectiveness research is you're using implementation strategies. You're probably not calling it that, but we do tons of things in effectiveness research to support adoption, delivery of the intervention with fidelity, potentially even changing so we can get it paid for, all sorts of things that we do to make our study work, our effectiveness research study actually happen. Those things can be informative to implementation research, but essentially we're not focused on those, right? They're in the background. You may have a section in your manuscript that's about this long that talks about what you did to help the system support delivery. In an implementation study, it's completely flipped. So foreground, background, the intervention is still there. It's still important. We still want to know that it worked, and we want to have some evidence, especially that it didn't get worse or degrade because of our approach. But really now we are focused on implementation strategies, right? So because we have a primary focus on implementation strategies, our focus is also going to shift to implementation outcomes and the impact of implementation rather than the effectiveness of an intervention. So we'll be looking at things like, do people adopt it? What did it cost to deliver? What did it cost for, or what kind of costs were recouped by doing this intervention through bundled payments or fee for service? What level of fidelity were these interventionists able to deliver the intervention at? How many people did it reach? And then was it sustained, or what aspects of sustainment do we need to consider too? So again, we're not discarding the intervention's effectiveness. There are what are called pure implementation studies, where something is basically shown to be so evidence-based that we know it's just an issue of making sure that implementation is done well and the intervention is going to have the effects. But that's relatively rare. And it's, those are difficult studies to get funded because you got to pass reviewers. So in most situations, we do have some clinical and health outcome, even if we're focused primarily or almost exclusively on implementation strategies in the implementing system. Does this make anybody nervous? You're like, oh, I'm not, this is like so different than what I do. Okay. A little bit different. Okay. So we'll talk more about these outcomes and whatnot. So let's think about some common implementation research aims that you might encounter. This came from a systematic review. Actually, no, sorry, it was called a mapping review of the literature of HIV implementation science that we did in 2020. And we were able to pull basically all these like common themes about what kind of research aims are people doing. So a lot of aims have to do with just understanding context. Okay, so understanding barriers and facilitators to implementation. Right? So what got in the way, what could get in the way of implementing this intervention to its full. There's also quite a bit of research that aims to just adapt an evidence-based thing. So we have something that we know worked, down the street at our hospital here at Utah. What if we wanted to have it go national to other academic medical centers? Well, they don't all look like us. They have different barriers, facilitators. Their intervention might need, or this intervention might need to be adapted to fit that context. We also want to evaluate the impact of an adapted thing. So if you adapt an intervention, you often want to make sure that the adaptations you made didn't actually negatively affect the clinical effectiveness. So if we adapt, which is an implementation strategy, we often want to demonstrate that it has the same effect that it did. There's also a very common aim of just selecting, developing, adapting, or designing your implementation strategy, right? So getting together with your partners, with community stakeholders, all those different folks who might be involved in implementation or be affected by it, to figure out how do we actually implement this in a specific system, a specific community. And then, of course, at 5, 6, and 7, now we are actually getting into that official definition of implementation research, which is evaluating strategies. So in pilot studies and small, like R21 type studies, a lot of people evaluate the feasibility and acceptability of strategies, not the intervention. That's already been established. We can do them simultaneously, but in implementation research, we're really focused on the feasibility and acceptability of the strategy that we're using to implement a particular thing. We also evaluate or test the impact of a strategy. So when we apply a strategy, what implementation outcomes does it achieve? And of course, are they better typically than a control condition, implementation as usual? Or in the case of number 7, you can compare the impact of one or more implementation strategies. So there's several kinds of study designs for each of these, last 3 or 4. But really, you can kind of think about this as like typical like randomized controlled trial or typical just like 1 or 2 arm study design. Number 7 here is going to be kind of analogous to comparative effectiveness, but we've called it comparative implementation trials or head-to-head implementation trials, where you have 2 different implementation strategies for the same exact intervention, and you want to see which one is better. It's not always which one's better in every way. It's like which one is like reaching more people at a lower cost, which one maximizes effectiveness while being still adoptable. You're kind of like looking at the totality of implementation outcomes to figure this out. But you also can do things like smart studies, factorial designs, other ways of like looking at combinations of implementation strategies so that you can compare those different conditions. Any questions about these aims? Or potential, I guess, research questions almost too? Yeah.
It's like, that sounds like.
It is.
So that's something you would call it implementation research in the context of studying it alongside implementation.
Well, so there's 2 reasons why it's implementation research. One is that the process of adaptation is itself an implementation strategy. So you're more or less testing whether or not your strategy was effective through clinical effectiveness outcomes. You're also typically, in this case, also going to look at implementation outcomes of the adapted thing, because we often adapt to make it more implementable. So we want to see, is it more acceptable? Is it now more adoptable? Was fidelity improved? So it's kind of both sides of the coin. But yes, that is one of the only places here where effectiveness is still playing a pretty significant role. Yeah, good catch. Okay, I'm going to keep moving. So there's several key elements of implementation research. We've already talked about a lot of them today. So theories, models, and frameworks are a key element. Workshop on the 24th of January. Implementation outcomes, very critical, that we'll talk a little bit about today, but dig more into on April 11th. Implementation strategies are a key element that we'll talk about today. Contextual factors we'll also talk about today. And then research design and hybrid studies. We'll talk about some resources, but this is something that I cover in detail in the Advanced D&I Methods course that's offered in the spring. So just to kind of help put all of these pieces together. So those are, basically presented as sort of disparate things, but of course we know we have to have sort of an integrated whole picture for a complex or large scale implementation research study. So in a paper in implementation science in 2020, my colleagues and I proposed, or at least just put forward in words, this was not our, only our thinking. This was definitely borrowed from a lot of other folks who are smarter than we are. But we came up with this generalized theory of implementation research, which essentially is 3 core assumptions or kind of statements about the kind of research that we do. So one underlying theory is that the implementation strategies that we select should be related to the implementation context, right? The specific barriers, facilitators, and other determinants in the setting we are going to be implementing in, and our specific evidence-based thing, right? So there has to be more or less a 3-part Venn diagram that all overlaps, right? I'll show this in a logic model format here in a minute. We also say that, or have to assume that implementation strategies are working through specific mechanisms to impact implementation outcomes as the first most proximal thing. So those implementation outcomes are the direct proximal impact of the strategy, which then further downstream relate to the clinical outcomes of the thing. So I'll illustrate this here in a sec. So the one thing that this kind of illustrates is what we are now calling Cosmos, thanks to Paul, which essentially means this linking conceptually or empirically in some studies the contextual factors with implementation strategies, with their implementation mechanisms, with implementation outcomes. Notice I couldn't put implementation in front of everything, but yeah, essentially the implementation mechanisms and outcomes. So we'll look at that here in a sec. So when we talk about implementation outcomes, this is really where we often start in implementation research. Really, what are we trying to achieve? Okay. You can't just say we're trying to improve health. That's not specific enough. It's also not an implementation research question. And we'll get into more about research questions here in a bit. But essentially, in the context of a project, how do we actually demonstrate that what we did worked, right? So implementation outcomes are defined as the effects of deliberate and purposive actions, think implementation strategies, to implement new treatments, practices, or services. They can be indicators of implementation success. They can be proximal indicators of implementation processes. They can also be key intermediate outcomes in relation to service or clinical outcomes. So most of us are probably familiar, at least, with like the concept of higher fidelity, typically positively associated with higher clinical effectiveness. That is probably the best example of an implementation outcome being related to a clinical outcome, but we'll look at some more examples here in a bit. So in this case, think system outcomes, not patient outcomes, right? One of the most common, actually the most common and most cited and used implementation evaluation framework is REAIM. We'll go into each of these here on the next slide, but essentially it's the reach, effectiveness, adoption, implementation, and maintenance of an intervention when it's delivered sort of in an implementation context. So I really like this distinction that was made by Laura Damschroeder in a 2022 paper, which is this difference between what they called anticipated outcomes, or what I also think about as sort of perceptual or perceived outcomes, and then actual outcomes, right? Ones that have actual service delivery associated with them. So on our left-hand side of anticipated outcomes, we have things like acceptability, which is, does the site, delivery agents, or recipients of an intervention or an implementation strategy, don't forget this is sort of a multi-level problem, do they find it palatable? Is it acceptable to them? Adoptability. So this is the likelihood that sites and delivery agents will adopt and deliver a particular thing. We also have the appropriateness, which is often overlooked, but it can be really relevant to certain things. And I'll actually talk about this in one of the examples today. This is really the fit with the mission and goals of a site and its delivery agents, right? It also has to do with your expectation about what kind of service you get as a patient or a recipient of interventions in a particular setting. We also have feasibility, which is really the alignment with available or expected resources. It really is this feasible to deliver given our other resource and personnel constraints? And then sustainability, can we keep this going? When we look at actual outcomes, we have actual adoption, right? Did the site or delivery agent actually demonstrate uptake of the intervention? You can also look at adoption of strategies. In the implementation construct, that's multifaceted within REAIM. We have fidelity, which is really, was it delivered as intended? We have adaptation. And so this is what needed to be adapted or what adaptations happened during the course of implementation to make it more feasible, acceptable, et cetera. What did it cost? For costs, we are typically concerned most basically with budget impact. I mean, quite literally, what would this cost on a budget of a particular organization to do it for another year? We sometimes look at return on investment or cost benefit. And then we also look at some cost effectiveness, but it's typically cost effectiveness of the strategies, not cost effectiveness of the intervention, because that happens in other kinds of research. We can also look at speed and efficiency, basically how quickly are we able to get up to a certain level of fidelity or this intervention to a certain proportion of the population. And some of that efficiency does get sort of examined within cost as well. Under the concept of reach, this is really, can you get or did you get the intervention to the intended population, right? So I'll give an example here in a second about that. And then sustainment is really, did delivery continue over time and to what degree, okay? So again, sustainability is sort of a characteristic of an intervention or an implementation plan versus sustainment is hard data that it actually did continue beyond a particular point. Any questions about these outcomes? Okay, there's a few more outcome slides, so if any questions pop up. I got rid of my animations because they were bananas. But I'll just show you what this is. This is a great slide about why you should care about implementation outcomes and why we care about many of them, not just one, because of their interrelatedness. So on our left-hand side, you can think about the effect size of our evidence-based thing when delivered sort of fully as intended. Okay, so if we deliver an intervention that has a average effect size of 1.0, let's just make our math really easy. The things we're really interested in about that intervention now in the context of an implementation study is first, can we get sites and people to adopt it? Okay. Once we actually get adoption, do the intervention deliverers or providers deliver it with fidelity? Do they actually reach the intended population? In this case, it's basically those people in the numerator who got the intervention over the number of people who met eligibility criteria who had the opportunity but didn't get it. Okay. So sometimes didn't get it is a process of it wasn't offered. So that's an issue with the delivery system, the delivery agents. Sometimes it's that they were offered and they weren't able to access, which could be an issue related to participant characteristics, social determinants of health, structural factors, other things. But essentially really digging into how many people got it among who should have helps you really understand like how much benefit could have been realized that wasn't. And then the final thing is, will organizations sustain it over time, or was it able to be sustained? I typically ask this question because it's sort of a eye-popping one, and have the little animations in here. But with a 1.0 effect size, if you achieve 50% at every one of these, and I'll tell you right now from the many studies I've done in implementation research, 50% is good for a lot of these outcomes. You can look at the combined effect of all of that at a population impact level or population benefit level is only 6%. That basically means you're leaving 94% of the potential maximal benefit of implementing this thing on the table. Ugh, that's really disheartening. Okay. What about if we get to a 90% threshold? God, I'd love to get 90%. That would be a JAMA publication for sure. You're still 65% population impact. There are still enough sites that have not adopted, enough delivery agents that are delivering it with such low fidelity it's not actually working, and enough people that you're missing. And then, of course, there's probably sites and people who do not sustain over time that you're actually only achieving 65% of the possible benefit. So this is kind of a population health, public health impact kind of perspective on things. And you can look at these sort of rates within any size catchment area, okay? So let's go back to our policy example. Let's say there's a national policy, Affordable Care Act, affected the entire country, right? It changed practice in so many ways for so many people, particularly preventive services. So you could look at the entire country as our catchment area and say, okay, we changed the law to make it so much easier to get preventive screening for X. How many people actually now do that? How many sites build for preventive screening services? How many providers actually did the test like they were supposed to? How many people did it reach? Was it sustained over time? We can look at that at that kind of level. We can also look at this at like a single adopting organization. Like you could literally have an N of 1 for your adopting site, but then have several providers that could adopt, and we only got 50%, 90%. Then you can look at them as well. And you can look at their population or their potential reach on that very micro level. So this is all scalable to your study or your study size. Any questions about this? Any thoughts?
A little more on how to actually measure fidelity and measure adoption.
We can. It is a topic for that April one, but I don't want to leave you hanging until April. So adoption's fairly easy in most situations. This is typically defined as a particular activity or particular just discrete act. So for adoption at a site level, I do a lot of work in primary care. We're typically working with practice managers and like some operation lead that's, oversees programming. They are considered an adopted site once somebody actually delivers the intervention. They're a potential adopter in that sort of preparation phase if they said, yes, we're interested in adopting. But until they actually deliver the intervention, they're not really an adopter. There is a more lax definition of basically like adoption is sort of defined as people who are interested in doing it, and whether they actually get to it is not as relevant. I tend to want to put it on something that's really easily defined, discrete. So as soon as somebody delivers the intervention, as soon as they get training in an intervention, even if it's never delivered, that could be your bar or metric for adoption. Similarly at a interventionist level. So I would not consider an interventionist as an adopter until they've actually delivered the intervention. You can also look at adoption of different aspects. So we often look at adoption of the training and then how many people actually go on to deliver as two different metrics, because that can help you understand is your training actually not very good. If you have a lot of people who say, yeah, I want to do this, but then nobody ever does it, probably something wrong with your training approach. For fidelity, that's a bigger question for sure. Oftentimes we try to use the same observational rating systems, adherence checklists, things like that we used in effectiveness and efficacy research. Sometimes that is not possible because that, in some of the work that I do, that requires like one-on-one observation. It requires, videotaping and then coding. So we start to look at other metrics sort of higher up that are, we're all the different components of an intervention delivered for every family, but we don't know exactly how well they were delivered in the actual patient deliverer encounter. So there's different ways to look at fidelity, but there's definitely a longer topic about how to do that. Reach, again, typically if you're working in a system that has a EHR or other kind of data system, you can track how many people get the intervention. That is almost always tracked. The thing that's not always tracked is the denominator, right? How many people actually were offered the intervention but said no? So we sometimes have to add data fields or radio buttons for people to say, yep, I talked to them about this, I referred, good luck. And then track their actual receipt later. So we can also confirm reach rates with with billing and payer data. We can check it with program data as well for people who actually delivered, who was actually in attendance, et cetera. So different ways to get the reach data. And then sustainment that's a long conversation too, but essentially that could be essentially how many people continue to adopt. Did your reach rate continue to be sort of on par with what it was at the end of the first 12 months, that kind of thing, those kind of metrics. Enough for today? Okay. Got you interested in the April workshop?
Well, I'm specifically thinking of it because I currently have a project going on where I'm measuring fidelity of a measurement, and it's a really complicated way of doing it, and it's very challenging.
Yep.
I'm just trying to get better ideas.
Yeah. Yeah, I mean, people have come up with like some pretty creative ways of doing things. There's now automated and like machine learning based fidelity measures. They're expensive to create. There's also what we used to call unobtrusive measurement, where there are some like when you do I do guideline implementation, there are often indicators of whether you are guideline adherent just in your clinical practice in the EHR itself. And so you can actually just pull existing data as an indicator of whether or not the guidelines were followed. So there's different ways of getting it depending on the type of intervention, but I'm not kidding. This is probably one of the things that we struggle with the most in most of our implementation studies is even at the proposal stage, like how are we actually going to measure this? And then of course, trying to get that into practice once you get funded is another challenge too. So definitely worth thinking about. This is one of those places where you should start infusing sort of implementation thinking in intervention development and testing, because you can develop a fidelity measure that you use in your efficacy trial that is actually could be done in implementation research rather than something that you could only do with NIH funding or VA funding or something. Any other? I thought I saw one more hand before. Yeah.
Overarching question about how, because I'm assuming this implementation research and these outcomes don't exist in like a bubble, so you kind of have to ask, the adopters, will this even be effective? Do you think, how is there like a community component to this? Because you can't just take a program that's evidence-based and throw it out there and then measure like what happens. So that's just been kind of on my mind this whole time, like how it, or maybe that's.
It's not really. That's again another topic for a different way. But let's go back to our common research aims. So when we're trying to understand barriers to facilitators, you better be asking your partners what they experience. This can't just be like what I think is going to be the barrier facilitator. It really has to be like data collected directly from the potential adopters and implementers of the intervention. And typically multi-method. So we'll be doing surveys, qualitative interviews. You know, I know we've talked a lot about doing workflow analysis, that often you're actually in the clinic observing clinic procedures. Like, I mean, it gets to that level of understanding what is going on. We use co-design, human-centered design as well in this to do that. When you're adapting an evidence-based thing, same thing. You have to know context, and you have to get input from the people that you're actually going to be adopting to what they need to adapt. When you go further down, I think this is another really key place about when you're actually picking the implementation strategies. There's always a little bit of a tension between what the site thinks is going to be helpful for them versus what the literature says. So when you're putting together a grant proposal, I hate to say, like, sometimes we listen to our partner and then we like only put the stuff in that's evidence-based, but then we do what they said in the grant and the things that were evidence-based. But, you know, for the purpose of getting funded. But they really need to be involved in the strategies, right? Because we don't want to propose strategies that they either don't think are going to work or they say are just not feasible, right? Because you're going to have a failed implementation in the first 3 months if that happens. So partners should really be engaged at all stages. I think too, even when you get to these last stages of actually just evaluating and testing, they should be involved in whether or not you randomize, what kind of study design is appropriate. Are they willing to be randomized to, you know, basically a control condition or implementation as usual? They probably should help you both define and come up with your outcome metrics. Similar situation, there are times when the outcome metrics that our partners were interested in are not ones that reviewers are going to care about or that the science cares about. And we know that that mismatch exists. So we often just don't put those in the grant, but we still measure them anyway. And when we do our, like, you know, report backs, our like executive summaries, all this stuff with our partners, we lead with the things they cared about, right? So if they don't care about our, you know, fancy implementation metrics, fine, like, that's great. We will measure the stuff that you want and help you with that part of it. So yeah, they should be involved at all these stages. Jonathan.
So like a big picture question.
Sure.
About the data.
Yeah.
I'm thinking of some settings that like therapeutics, that you have a company that develops a drug medicine, and their implementation is like kind of probably different. It's probably more like, we get this product out.
Yeah.
And then there might be some things about like after the patent wears out, you can adapt like kind of off-brand or something.
Sure.
Like some connections, but this feels to me like it really applies to. Yeah, I'm not going to get your insight in like what it applies to, but like working with some of the projects we've heard on, they're very like person-based. They're working together with individuals. They're very programmatic versus like. Yeah.
No, for sure. So actually in Jenny's portion that's coming up very shortly, she'll talk more about like what are things, which yeah, again, very specific. But it does cover that whole gamut of what you're talking about, everything from pills to policies to practices, procedures, et cetera. Everything in between can be an evidence-based thing. And then, yes, there are like slight changes to all these things depending on exactly what the thing is. So the policy question was a good one to show some of that too.
Question, when in a controlled like research design, like you were just talking about, I imagine that in studying these implementation strategies, there's probably a higher risk of kind of like cross-arm contamination than in some other intervention deliveries. And are there specific ways that you address that within implementation research?
Yes, yes, and yes. So this is one of those things that, you know, again, probably the topic for like design talk. The majority of these studies are cluster randomized for exactly the reason you're talking about, that when we do strategies at, you know, the provider level, if they work within teams or with other providers, some of those strategies you can't disentangle from like clinic operations, right? So if I'm changing a clinic's operations, I can't just do that for 4 people, right? It's for everybody, right? If I'm asking you to change your data system, change your reporting, we're going to incentivize use of this evidence-based intervention, like everyone's going to be affected. So we often have to like, you know, we have to settle in on what are the most important or most like interested implementation strategies. And then sometimes you're kind of stuck with the level of randomization being equivalent to the level of that strategy. Otherwise, you're right. You have these issues of contamination potential or arm crossover. So that's where we get system level randomization, county level randomization, country level randomization. And there are examples of all of those in the literature. It's just very uncommon, and it's similarly for patients, right? If you were asking providers in a real world context, your patient's going to be randomly assigned to whether or not they get this intervention. You deliver the intervention to those who are randomly assigned, but don't for the others. Like if you believe that's a better intervention, like you're not going to not deliver. I mean, it's just, it's just unrealistic. So there's definitely ways that we do it. It's typically at the design phase. And then most studies that are done well have some mechanism for looking at contamination. So just, trying to see if there is any spillover or issues with that. Okay, so let's talk a little bit about implementation research questions. This is surprisingly one of the hardest things for new learners is to really come up with a good implementation research question. We're all great at coming up with good clinical questions because they're all about effectiveness, but you'll notice that none of these questions have effectiveness in them when I start getting into these. So the process really of coming up with your implementation research question is really derived from your implementation outcome. What are you trying to achieve? And then a little bit and then it informs, of course, your study design. So your problem, this is just a common scenario. So your evidence-based intervention is available, like people know it's out there, okay, but systems aren't using it. So the question kind of is basically what implementation strategies lead to adoption of the EBI? So adoption is your first problem here, okay? People are not adopting. So a primary implementation question here might just be purely, how do we get people to adopt this thing that's out there? People are aware of it, they're just not using it. So another question could be your evidence-based interventions in place, like your organization has adopted it, but few people are actually getting it. Okay, so few actual recipients or patients actually get the intervention. So a question here could be, does X implementation strategy increase reach of the evidence-based intervention? You're just simply testing strategies related to increasing reach. Another common problem is the EBI is available, but the outcomes are poor. So people are using this new thing that's supposed to work, but the effectiveness data actually is showing that it's not actually that good, right? It's not actually working very well. Well, the question obviously is the intervention not very good? Maybe the first thought you had. But the more common problem is if it's a really robust intervention, it's actually that the implementation is not good. And that's the reason that the effectiveness is not showing up in the data. So your question can be something like, can retraining and ongoing monitoring to implementation strategies increase fidelity of delivery? And of course, the extension of that is, if we increase fidelity, does that actually improve our clinical effectiveness outcomes? Okay, that's the assumption of that being there. So those are kind of a little precursor. I have a little bit more about how to generate implementation research questions, and I'll take you through a funded example of sort of the premise of getting into like what we proposed. But I'm going to turn it over to Jenny here in a sec after we answer more questions. Yeah.
Line down there, can you train and ongoing monitor increase fidelity to delivery? The extension of that is to improve clinical outcomes. Basically obligated in the study to actually show that increased fidelity has changed clinical outcomes. I mean, is that something that you routinely try to do?
If you can get the data to do that, yes. There are situations where it's really hard to get the data to actually do like a mediational model. And actually just on this topic, so this is a perfect case of a mediational model, right? You have exposure as your implementation strategy, fidelity as your potential mediator or your proximal, intervention target and outcome, and then your downstream or your direct path is to clinical effectiveness outcomes. Oftentimes, because of the nested structure and cluster randomization that happens in these studies, we're not powered to do a full test of mediation like you would like a Barron and Kenny or something like that. But what is often common is that you do just the B path. Right? So you're showing, is there that relationship between the fidelity and the outcome? And then you can do the A path independently as well. Like, did our strategy actually improve fidelity? So in situations where you just can't do a formal test of mediation, it's acceptable to do both paths. And then of course, if you're well powered, you could potentially do like a, combination, but yeah.
In terms of how mature the evidence-based intervention has to be, I'm curious about circumstances like the pandemic or emerging clinical issues that the evidence may not be fully formed, but people really want to see something get going. Yeah. And we are armed with this knowledge about how the infrastructure, the setting, the system, all of these things will eventually lead to either high fidelity, eventual good outcomes, et cetera. So how do you balance trying to generate something that thing is still evolving, but you're trying to create the infrastructure so that when that thing is mature, it is more effective? You just not even consider it as an implementation science question? Like, I'm curious about.
No, it is. I think it's actually, I'll repeat questions. So this question is about essentially when evidence-based interventions don't yet have full evidence, but they're going to be implemented and they're going to be moved into practice. So this does happen, and your example was very appropriate. Like with the pandemic, as soon as we knew that vaccines were safe and likely effective, they got moved out very quickly. So that's there's two kind of major situations that this happens. One is public health imperative, which is exactly what the pandemic was. The other is just purely clinical inertia. And clinical inertia happens often when something comes out that is so much better or replaces a gap where nothing else exists, that adoption happens rapidly. And there really is there's more of a pressure to get things actually in practice and benefiting people than there is to continue to do more randomized trials, because there's no alternative, or it's like so much better than the existing practice that we just really need to do it. In those situations, we typically do apply like the hybrid effectiveness implementation type work, where you're gathering evidence to contribute to the evidence base of the intervention at the same time that you are trying to figure out how to best implement it. And then, you could potentially layer on a trial of strategies on top of that. But often the first step is just, hey, this thing is now in the wild, and we just need to figure out how people are doing it, what barriers are they encountering, what strategies seem to be effective for those barriers, and then we help other sites essentially learn from other people. And then you can start to apply some of the more like randomized designs once you start to really figure out what the problems are. So you can do things simultaneously and not have to worry for perfect effectiveness data.
Yeah, and I'd say ideally it'd be nice to be able to switch out the thing, get something better down the pipe, so that.
Yeah.
That's.
No, that's a good point about switching out. So I mean, in many situations, you are doing de-implementation at the same time you're implementing. You are trying to replace an ineffective or lower quality practice with something that is hopefully going to have better outcomes. So you're simultaneously doing it. Other situations, like you're trying to embed something in a system where intervention for the health outcome you're trying to change does not exist. So a good example of that is, working like doing blood pressure in barbershops. You're not replacing them doing anything. They were never doing blood pressure monitoring before that. Now you're training them to do that, and it's more about integration than it is actually just replacing something else. Yeah, I'll turn it over to Jenny. I hope. Welcome back.
Okay. All right. Hi, everyone. I was a little bit late this morning. I had competing meetings. So I'm Jenny Hill. I work with JD in the DIS core. I also have a role in the community collaboration and engagement core. I think JD has already kind of set the stage, but talking to and working in partnership with your stakeholders is a key element. So community engagement and partnership engagement is kind of threaded throughout what all we do in implementation science. I'm going to take over here and talk just a little bit. Maybe better move this, Liz. Can they hear me? Oh, it's the computer. Oh, good. That's why JD had it turned away from it. I thought I'm just too short. Okay, so I'm going to talk a little bit about context, and every time I've looked at this, it was in JD's slide deck, it's made me giggle over the last week, because this is one of the best ways to really think about context. What it means really is dependent upon the setting or situation that you are in. And when we think about implementation science, a lot of people will say context is king or queen, depending on kind of your frame of reference, but it's that important to what we do. Understanding the context in which you're trying to implement your evidence-based thing is essential for success in adoption implementation. It's critical for fidelity and for sustainability. It becomes really important. So how do we define context? These are just a sample of the definitions you will find in the implementation science literature. Kind of the shortest version of this is that context is everything that is not the EBI or the evidence-based intervention. That's an overly simplistic way to think about it because context, that leaves everything else, right? Outside of the thing that you have evidence for that you're trying to get put into practice. Often in reality, there's overlap between intervention factors and context, and it ignores, kind of thinking of it too simplistically, ignores the choices that our implementers or delivery agents make all the time in the field when they're doing the thing we want them to do. Context can also be thought of as effect modifiers for implementation or effectiveness. So you may need to decide if you want to adapt the intervention, adapt your implementation strategies. You might need to do both. And you want to acknowledge and measure the impact of context on your outcomes and address the factor. It also informs how we think about spread. So I hit on a few things there when thinking about context. It's complex. And for those of us who are maybe trained in behavioral science, the Squires article that I reference here really thinks about context in a social ecological framework. We call this an ICON framework. So context can be defined at least 3 levels: the micro level, who are the actors; the meso, the organizational; and then the macro, which are the external. For those of you who are in kind of the CFR world, the Consolidated Framework for Implementation Research, you might think about inner context and outer context, or inner setting and outer context, right? So these are the situations in which your thing is going to have to operate. It also includes the people who are both going to be doing the thing and who also have to support the adoption of the thing into the system or the organization. And so when we think about context, you're often thinking about it from multiple levels and multiple people. So defining those early and often and understanding them really might be your starting point when we think about an implementation science project. So some things to think about that. We often use this term actors. These are the individuals or groups and maybe the characteristics of the individuals or groups that are going to be involved in the care delivery or the doing of your evidence-based things. So we often you can call them actors in kind of the abstract. They might be your delivery agents. They might be the clinicians. They're going to be the people who have to do the thing. When we think at the organizational level, again, that's kind of an embedded problem, right? When we think about context, you have your decision makers, the people who are going to decide whether you can do this thing. That's related to climate and structures. What is the environment of the organization? What is the economic arrangements that are in place that might impact this? What's your organizational size, type of ownership? What are kind of the technology features or resources? So, right, like this is really complicated. And as JD pointed out, you can think about your adoption as a unit of one. It's one clinic. That's the simplest form. But even within that clinic, you have kind of a variety of contextual factors that you'll want to consider. This gets much more complicated when you have a multi-site setting, right? You have 27 clinics. There is context that's associated with each one of them. If it's a centralized system, those variables might be constrained somewhat or more similar. If it's a decentralized system, I do a lot of work in rural healthcare, and one rural healthcare practice is one rural healthcare practice. The next one might be completely different. And so context comes up in these ways, right? So the social behavior, what's the kind of norms and organizational norms and relationships within and between the organizations you're trying to work with? How do they respond to change? We often think about organizational readiness to do the thing you're asking them to do, and this can be organizational readiness to change. We can think of this at the provider level. Are they ready to change their clinical practice and their approach to that clinical practice? You can also think of this at the organizational level. Are they ready to adopt something new or different in terms of how they've done it? And last is the processes. We often think about what are the channels or methods by which we can do communication, decision-making, and all sorts of evaluation that comes into context. And kind of outside the individuals who are doing the things, the organizations in which they're doing this thing, we often have these external factors that if we think of a social ecological, there are one or two layers up. What are the community-based contexts? What is the social political context? Using the Affordable Care Act, that's all states could adapt that, but we have factors at the state level where they may have chosen not to implement that, right? Which impacts everyone below that in terms of context. So when we think about context, it's multi-level. It includes multiple people, and you really want to think about context early in your implementation project and throughout that project as you go. So how do we begin to think about context? I have probably what's going to be an unsatisfactory answer for those of you today, because we need a whole day to talk about it. But the first, I really think, is starting with your theories, models, and frameworks, which we've kind of touched on. There's a whole host of theory models and frameworks in dissemination and implementation science that can help you think about this. I'm showing Roger's diffusions of innovation, which is kind of one of the original ways we think of. But for diffusion to happen, there's a social setting or system in which that information moves through this setting, right? That's a classic example of context. You have something new, you need to get it into the system. How does it move, and what are the characteristics, social and physical, of that system are really important. So we can think about this in terms of an evidence-based thing being a medication or a vaccine that has been shown to be effective. So it's not only about the serum and the syringe, right? We have to create the medication, we have to test that it's effective, we have to have a mode to get it into kind of the human setting. So this works, right? This is our evidence-based thing. So if we take the consideration of this thing, a vaccine, this particular vaccine or medication happens to need cold refrigeration or cold chain logistics, if you will. So if we start to think about, okay, we now have an effective medication or a thing, how do we get it to people? So in this setting, if we were going to try and get this medication into practice, this example is in Central Africa, and it needs cold chain logistics. If you guys look at this picture, what context, what beyond the medication are going to be factors that we want to consider?
The weather,
The weather. Why the weather?
because if it requires, cold temperatures, the environmental context is gonna affect
Right.
how much refrigeration you need, when you need it.
Right. So the weather is one example of context. What else?
Distance it needs to go.
Distance, how far do you have to transport it? What else? Condition of the road,
Mode of
mode of transport, other things.
Yeah, it's got like fumes that it's spewing.
So it's contributing to the hot weather. So we have a poorly designed truck. What else about the truck?
Fuel.
Has fuel? Does this look like a refrigerated trailer system? Absolutely not, right? And so those are a lot of the things you guys have thought about: the environment, kind of the bigger environment. We've thought about the road, the truck itself. What about the people in this system? What if we think about the actors, the people who have to do it? Who else is in this? Oh yeah, I forgot. We have a little. Yeah, the driver's a factor, right? We're relying on him or her to do their job, right? To be able to transmit. What if they stop for a 2-hour break? Turn off the trailer. That blows our cold chain logistics, right? So it seems silly, but these are really practical ways we think about it. And we've got all the things. You guys got all of them almost. Look at Julie, you started at the beginning. You've seen this before. The one that's kind of really unseen is everything and every person that it took to get those vaccines on the truck in the first place, right? You have a plan. So you have this whole logistics that happen kind of behind the scenes before it even comes. All of this is context, right? So, and if we think about our evidence-based thing is really simple, we've created this medication, it works, we just got to get it to people, right? Well, that's a lot harder to do in practice or in reality. And this is really the questions for implementation science, right? We have the evidence-based thing. How do we actually get it to the patient so it can do the most good or have the intended population health impact that we're trying to? So when we think about kind of context, you may have to consider all of these. We also recognize that not everything about context is changeable or under our control, right? So part of our work with context is to acknowledge it's there. You want to minimize or mitigate what you can, but sometimes you might need to design a strategy that overcomes something you cannot change. It's immutable. So I don't want you to think that you have to change everything about context, but it's more about understanding what can or cannot be changed. And often you will design your implementation strategies with an understanding of context. So it's most likely to work in the context or setting that you're dealt.
Good example of that, you think about the road, right? So two
Oh, yeah.
solutions. One, you can repave the roads. Good luck. What's an easier solution? You can fly it, right? You can modify the truck, make sure the truck is just four-wheel drive capable, right? It's not gonna break down. Much easier solution than.
And you can also think about models in which does it have to come that far? Does it have to go 800 miles over road, or could you have a distribution? That's the Amazon model, right? They've hacked that. You're not that far. You can get your goods in a day or two, right? So that's an example.
And this sort of gets to Diana's question about the state of evidence or knowledge about the thing. Could we also think about when we're creating the thing that we think about these issues?
Right.
So we try to develop a vaccine that does not require refrigeration.
Right.
That was Johnson & Johnson's approach.
Yeah.
'Cause
Right.
they knew that the whatever the RNA vaccines, those two were gonna be prohibited, and that was gonna limit distribution potential. Just a bunch of them.
And it's something we know, right? We know cold chain logistics are problematic, especially for vaccine and medication uptake. We haven't completely solved that problem, right? Because it works well in a lot of high income settings. It really does not work well in other settings. And I think as things become more chaotic, even in the United States, you think about situations like the hurricane in North Carolina and Southeast US, there's situations in which our context may not be as stable as we have planned it to be or have thought it would be, right? And so kind of understanding that. And so really you can think about hacking context in any one of those, depending on you as your researcher and your question, what's under your control is really the things you want to focus on in your implementation project. So we'll just take a pause here, and we thought we'll have a break after this, but kind of going into this break, since you guys have been sitting for a while, we thought it might be good to just kind of break up and have a little bit of dialogue or conversation and really thinking about context, because even if you don't have a specific implementation research project right now, you're all thinking about one. You all have projects that kind of are under your purview or kind of in your wheelhouse right now. And really just kind of teaming up with your table mates or people who are next to you, what are one or two factors that made it harder if we think about context, and what are one or two factors that made it easier? And for those of you who might have some background in CFIR, or even you don't even need to know CFIR to think about what are outer setting, what are inner setting, what is related to the intervention delivery person in your setting, recipients, intervention, and kind of process. So all things to kind of consider, but we'll have you guys take about 10 minutes and just converse with each other. Yeah, please.
Ongoing project where we're trying to implement routine collection of clinical outcomes in physical therapy practices here at the University of Utah. And I think one of the things that's made it really hard is that the promise measures, which have been basically mandated by the university as to be our system-wide outcome measures, are really difficult to use from a clinical decision-making standpoint with patients during the clinical encounter. The promise score doesn't really mean much to the clinician or the patient necessarily. That's a thing that made it hard. And there's not that many things that have actually made it easy, other than to say that we've had good IT support to actually help the measures be delivered to the patient. And whether or not the patient actually completes them is a whole different part of the project that we could talk about in this even context.
Yeah, so a couple different things. You have kind of patient and provider level, and then really you have these organizational level decisions that, promises there, you're required to do it. They've pushed it out. And this is really context. Great example. Thank you. Others who would like to share. Yeah.
I'll speak for me personally just a little bit. I think what makes this question difficult to answer is there's so many factors just in general. It's like, how do you know what to focus on? Even when you focus on the ones you can control, it's like, how do you prioritize the patients ones to get to? But we talked about like rural health research where it's difficult for people to have transportation or for us to travel to certain areas with budget constraints and stuff to get to, do a research session. And then we've also talked what makes it easier is having community partners who can tell you, these are some of the barriers or factors you should focus on because this is what we see that's most prominent, or, just having knowledge of someone who's in that field, boots on the ground, and can sort of ground you in knowing what to focus on and how to make your project better.
Great examples. Others.
We've never done clinical research, so anything on public health plan.
Great.
And I've been working on a project, we've been labeling it implementation research, but I don't know, is it health system strengthening, is it QI? Is it the typical stuff we normally do in public health? It's, diffusion of innovation.
Yeah.
Because it's very community, system based, but there's clinical side, but there's also national policy level folks that so it's been a challenge to figure out how to frame it.
Yeah, public health patient research is a little different of a thing,
Mhm.
but most of what we're talking about today applies. It's just you're thinking probably at a slightly different level than just like practice.
Yeah, and you can also think about your public health departments as your organizational unit, where in healthcare, we might think about a clinic or a hospital as kind of that setting level. And I think I'll just say out loud kind of for the public health lens, you're welcome in implementation science, that and community-based research. That's definitely where I sit kind of in this spectrum, 1 foot in clinical, 1 foot in community. A lot of the literature is in clinical healthcare settings. But I think there's more and more kind of who are wrestling with what you talked about, like how do we do this in maybe a complex system, in a disaggregated system where multiple organizations might have to be collaborating to do the thing you want done.
That's been trying to be effective or adoptable.
Right.
But, I mean, there's lots of barriers, but it's light, it's acceptable, but it's too expensive. But
It is an implementation research question. It is an implementation research question. Thank you. Others? Last burning thoughts on context? Ashley?
I work in our operations lab and, I oversee a core that's trying to implement a new software system to track specimens. House institutional biorepository. And, we've been working on this project for about a year and it's still going to continue. And there's a lot of factors in terms of what makes it harder and easier, harder being people, and their bandwidth primarily,
Yeah.
as well as, you know, their priorities. So in a lab, you know, people are really good at pipetting, doing the lab stuff. They're not so great at then taking time to do, you know, data entry in the computer. So we've been working to support the culture change there and also create bandwidth for them. It's, you know, really required a full leadership team to, you know, think about their time, how they're using it, and, you know, support that. So people has, you know, both leadership and, you know, staff has been what makes it harder and easier. That's the, you know, outside of all the little other details about the system. So I see like definitely, you know, the healthcare system is probably all people factors probably a lot of the time, right?
Yeah, like people factors are a key piece of this. Everything from the decision makers or leaders who have to kind of give buy-in or permission to do it. But I think actually what you bring up is a really important thing we all deal with is capacity of the team, the intervention deliverer, the physician, whoever is going to be doing the thing for them, understanding, do they have the capacity? And then what does capacity actually mean, which is a riff on your context question. Does that mean they don't have the skills or knowledge to do that thing, or they don't have the time to do that thing? They don't have the infrastructure or the tools they need in their workflow to do that. Once we understand those nuances, and I'll leave it as a cliffhanger after break, you can pick a strategy that addresses one of those things to help solve that problem, or at least remove that as a barrier to getting your thing adopted and implemented into common practice. So great example. I think we'll take a pause here. Sorry, I was looking for the clock. We have a 10-minute break now. I know you all have been kind of in the room with us. So we'll take a break. You guys can get up and stretch, get some water. We'll come back in 10 minutes. So that's about 10:48 or just Mountain Time for those of you who are online. We'll come back and pick up with strategies. Our next topic is I'm going to dive into what are strategies, and forgive me here, I'm going to go forward one slide and then I'll come back. So it occurred to me that maybe we should touch on or kind of highlight what is the thing before we dive into strategies, and how do we think about this, and how is it different than implementation strategies? And so this is an example and relevant to JD's work in terms of, we often think of the thing or our intervention in a variety of ways. And so implementation science, you'll often hear the 7 Ps in terms of what your evidence-based thing can be. So I'm trained as a behavioral scientist, so I often think of interventions or programs as my thing. But if you're in pharmaco, you might think of a pill as a treatment. So it can be a pill, it can be a program, it can be a practice, so clinical care guidelines. It can be a principle. So one of our guiding principles in this example is HIV treatment as prevention. It can be a product, it can be a policy, and it can be a procedure. So when we say kind of what is the thing you're doing, it typically needs to fall into one of these buckets, or it will fall into one of these buckets. And it should be evidence-based. And we could do a whole lecture on what does evidence-based mean. We certainly know what it means in the context of efficacy and effectiveness research, in terms of we have some randomized control trials that show this thing works under ideal situations or in real world settings. That's one version of evidence-based, but there's a broader lens when we think about evidence base in terms of, and matching it back to kind of context, we can think about, is this thing likely to work in this setting, right? And so our evidence, we have a set of evidence for our intervention or the thing we're going to do. We also want to think about, evidence related to our implementation strategies. So if this is our intervention, then how are strategies different? Or really, what are implementation strategies? So implementation strategies are the methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program or practice. And kind of implementation strategies are the stuff we do, the things we do to try and help people or places do the thing. And another way to kind of think about that is the how or the what, right? So implementation strategies are distinct from your intervention or your evidence-based thing. They should also have some evidence for them. So what are these strategies? This is the IOF, the Implementation Outcomes Framework. Did you already show this, JD? I can't remember if we had this earlier. Okay, so JD talked about implementation outcomes. Those are in that kind of middle box. We might have service clinical outcomes and then also patient outcomes. Are what is our EBI or our quality improvement, the thing we're trying to get into practice? Implementation strategies fit here. How do we get the thing into care, practice, or settings so that we have move implementation outcomes so we can have a service level outcome? And ultimately, how do we end up with a patient level outcome? So implementation strategies kind of fit in this box in between. So I provided the kind of definition of implementation strategies. I'll show a little bit on kind of what strategies exist. There's characteristics to your implementation strategies, and at the simplest version, they can be discrete, a single action or process. So reminders, audit and feedback, supervision. Strategies can also be bundled or multifaceted, meaning a combination of discrete strategies are used, and those strategies used together achieve a different outcome than each one of them on their own. So they can be kind of discrete or bundled. So how do we know what strategies to use or what are implementation strategies? There's a kind of a body of literature, and that I'm really just going to do two slides that I would say are really on the evolution of what are implementation strategies. This is an early article from Byron Powell's group, and they have 6 categories of implementation strategies. And these big buckets are plan, educate, finance, restructure, quality management, and attend to the policy content. So that's kind of where we started in implementation science with implementation strategies. The kind of current iteration of this is the expert recommendations for implementing change project, or ERIC project, led to ERIC strategies, which is how we often refer to these in kind of conversational ways with implementation science. And the ERIC compilation is went through a process in which they asked implementation researchers and experts in the field, kind of what are the strategies that are used? They looked at the evidence for those strategies, and the ERIC compilation is a set of 73 strategies in 9 content domains that are implementation strategies. So the ERIC taxonomy is really kind of a way to think about these or identifying strategies. So if you're kind of new to thinking about strategies, ERIC is a great place to start in terms of most of what we would think about as strategies are here. And so the big buckets are engage consumers, use evaluative and iterative strategies, changing infrastructure, adapt and tailor to context, developing stakeholder or partner relationships, financial strategies, supporting clinicians, providing interactive assistance, and then train and educate stakeholders. So these would be the big categories. So the ERIC compilation is heavily framed in healthcare settings or contexts. There's an article that came out, I think it's 2022, by Laura Bayless, and they really took the ERIC compilation and reframed it for community-based context. So I know we have at least one person who's in public health setting. And the strategies didn't change that much. The way they're described is more useful if you're outside of the clinical setting. So I think there's a couple different ways you can think about using these implementation strategies. So this is a place, if you're thinking about how do I select the strategy or the strategy I'm doing, is it something that exists and has an evidence base? This would be one place to think about that. So what are those, kind of coming back to this idea that we have characteristics of our strategies. Here's a couple examples of what are discrete strategies. And your strategy or how you select your strategy is really informed by context. And what did you identify as the barriers or facilitators in the context or settings in which you're working? So if you have a barrier that's lack of knowledge, training and interactive education would be two strategies you could select to address this barrier to implementation. Lack of motivation, incentives, that's the positive. The stick version is sanctions or supervision. You could do audit and feedback as a mechanism, and audit and feedback sometimes contains elements of goal setting, right? So if motivation is your problem, you could set a goal and work towards that goals. Belief and attitudes towards the intervention. So if you have folks that are resistant or not convinced that the thing is going to make their life better or make their patient's life better, you can think about how do we influence or use clinical champions or opinion leaders to change those beliefs or attitudes. So your implementation strategies are the thing you do, again, to help you adopt or implement your evidence-based intervention into your setting or into your clinical workflow. And so these are examples, these are discrete, they're well-defined, you typically deliver them and you can count and measure them as done or not done, right? So they're kind of a one-off thing. You can also have multifaceted implementation strategies, and this can be where you need to combine different individual discrete strategies into kind of a grouping or a bundling. You might think of these are additive. We have a healthcare collaborative, you have provider communication, and you have education and counseling for women. So all three of these are a discrete implementation strategy for your project. Perhaps you're doing each one of these. Here in this example, your strategy should be defined at the kind of level of the kind of influence, right? So a healthcare collaborative is a strategy that's designed for organizational change. Your provider communication is at your clinic provider level or your delivery agent level. And then education and counseling for women, if this is your patient, this is kind of at the patient level. So you can have an implementation strategy for each level that you've identified as necessary and kind of important when you're thinking about this. You guys have questions on kind of pairing the strategies? Another version of this is bundled strategies. And this is an example of where you're doing a whole bunch of strategies kind of as a process. And this is practice-based facilitation as an example. So you have a specific technical task such as data entry, report generation. You have kind of a project management level, offering expertise in managing a process for a practice-based team. You might have consulting or consultee-based feedback where you're offering expertise and providing direct answers or guidance to doing the practice-based thing. You have training, and then you have coaching. So these are all variations of kind of facilitation, and they can operate and be operationalized in different ways within your project.
Question about this bundled concept and specifying your strategies. So if facilitation is made up of a number of these actions, which are in and of themselves strategies, how do you decide what is the is the implementation strategy of the bundle that you're using, or are you looking at each component?
Yeah, and in this example, you bundle them because you said all of these are important,
Right.
right? And so we won't dive into it for today, but when you think about measurement, you have to have a way to know that all of these things are being done together. This is a whole. You could say you could do each one of these, but when you bundle them, you have some evidence that working together is going to be better or yield better outcomes than doing each one on their own.
But you don't know necessarily the relative contribution of each thing, and I'm dealing with a practice facilitation project
Yeah.
right now where in some sites, it's like they need a lot of one thing, and then other sites, they're like, we don't want any of that. So maybe that's a little bit too detailed.
No,
I find I sometimes struggle.
This is actually my example, so
Yeah.
So,
Yeah.
we often do practice facilitation because it's like one of the most common bundled strategies. And one of the hard things about practice facilitation, like some other bundled strategies too, is that these are all individually tailored to the clinic, right? So
Yeah.
you're totally right. You don't necessarily have a research design that allows you to test the independent contribution.
Yeah.
But this actual study that this came from, not Baker et al., but the paper we published, we used this and had, I think it was like 60 practices, all got practice facilitation as the bundled implementation strategy. That was the main thing we were focused on. They were all allowed to do any of the discrete strategies from within these 5 tasks, essentially. And then within that study, because we tracked that, we actually were able to look at the relative contribution. And we published a paper called Does Coaching Matter? So coaching has always been like a big thing in practice facilitation. Guess what?
No.
Contributes to 0% of the variance when you do everything else. Like basically coaching in and of itself didn't do anything when all the other things were done effectively. So yes, you would do it at both. But I think this goes back to an earlier question too about, it was Mike's question, about like randomization. So I would never ask a practice facilitator, this just gets into logistics, but also just practicality. You'd never ask a facilitator like, hey, you don't do any coaching, you don't do any doing tasks, you don't do that. Like, it's just like, okay, how are we gonna like artificially do that? So again, it's sort of like a practice facilitator's just like role is to do all of these things. And so it would be very hard to actually like experimentally test. So we do, I think we did a thing called regression tree analysis, which don't ask me to explain that. I did not. We got some really,
60 practices.
we got really cool figures.
Yeah, I think that's the other thing too, is that the ability to generate more granular evidence about these individuals. You just need bigger, you might not be working in that, so.
And I think to test it, you need bigger and bigger, but to understand it, I think my question for you, Julie, was going to be,
Yes.
well, do you have a way to measure in your practice facilitation how much they're doing any one of these things? Yeah.
Absolutely.
And so if you've kind of done that thought work going into it, you're able, even if not testing it through regression or with a fully powered sample, you can gather some evidence for what is working and what's contributing and not contributing to that, right? And so I was thinking like, it's really about understanding, do you have a method? You need a method. Maybe I should start there. You need a method to measure your implementation strategies. And from a grantsmanship, you have to have that included. So it's about identifying what your strategies are. Why do you think they're relevant in the context of your project? Why are they going to work? What's the evidence for them? And then following that all the way through to think about at what level are they operating? And do you have a method or mechanism by which to measure if they're being done or not, right? And so we often think about our implementation to the intervention and our dose of the intervention. It's a similar concept, but applied to your implementation strategies. How well are they done? And then what's the dose that was kind of done through the course of your project? The other thing when thinking about implementation strategies, you might need different strategies for different purposes within your study. You might need different strategies at different time points. And so it's, again, kind of really thinking through what is the purpose of that strategy in your project. If you're testing your strategy, you have a lot less latitude in terms of changing it or introducing new strategies. If your research question is to test the strategy. If you're just curious about the strategy, you're trying to gather information about it, you can deploy different strategies for different purposes and see how that works, right? Yeah, James.
Yeah, what is the typical process for how bundles of strategies are identified or built? Instead of kind of having a handful of discrete strategies that you're testing, when do you know that it's time to test it as a bundle?
when there's contingencies. When essentially the thing only works because it has the three components and they like independently may not work. So I think a good one is like, you know, like fidelity monitoring systems as a bundled strategy. You often have to have a fidelity measurement component, a potential feedback component, a remediation or supervision component. And if you just measure fidelity without having a remediation, without having a way to give feedback or even get the data back to the system, it wouldn't work. So there's a little bit of the contingency stuff. I think this is one of the fallacies, or at least like misconceptions, is that just because you do multiple strategies doesn't make it a bundled strategy. Your strategy can actually be like 4 discrete strategies, a bundled strategy, and a multi-component strategy all together. That becomes your whole strategy. I hate to say it, like strategy, like to refer to multiple things is always a little confusing, but you know, that's why we have to break it down and get a little bit more granular like this. So practice facilitation is a great example that it works because you have this whole toolkit of things you can do and you tailor it to the practice's needs and the intervention's needs. You're not going to see the same distribution of like these 5 buckets for every study because every intervention has a different need. So like in this example, we were doing blood pressure control. Report generation on a quarterly basis and feedback was a huge component of our intervention. And so there was a lot of doing tasks. In other places where we've used practice facilitation, that was not the case. And so like that time just shifted to other things, right? So it's still the same amount of time is being devoted, but because the intervention needed, you know, more training, that's where more time is spent. So, yeah.
So, sorry if I missed this, but so is the trademark of bundled strategy that they're all, it's kind of like they all start at the same time on the racetrack? Or, okay. So if you have 4 discrete strategies, then what's the kind of trademark between 4 discrete versus a bundle?
It is the contingency that they have to be delivered together.
But not at the same time.
Not necessarily.
So the 4 discrete can be delivered at different times,
Yeah.
not necessarily together.
No, but it's basically that they're all required or all necessary to achieve the effect, the overall effect.
But not together.
Yeah.
Which is bundled.
No, temporal is different. Temporal is like not even related to this question.
Okay.
Yeah. And so practice facilitation is another like weird example that in this case, practice facilitation is also one implementation actor too. It's a practice facilitator. One person does all of these things. In other bundled situations, you have like 4 discrete strategies. You may have a different implementer or different actor for all of them. So there's lots of different like ways to like slice and dice, and like the point is like really just being very specific, getting down to, you know, the most relevant granular level that you need to.
Yeah. How much do you try to control the, for example, in this case, the practices implementation of the bundle, like the example where you've got one practice that just really doesn't want one part of the bundle.
Yep.
And so you kind of have like this, like a dosage intensity
Yep.
effect. You just describe your strategy as this is what we're offering and do it, and we'll just take it as like an intention to treat offering a strategy.
That's how we typically do it. I think Jenny's point too, like if it's the strategy you're testing, it needs to have a protocol that you at least try to stick to. If you're just trying to understand it, like it's less necessary to have that protocol. But in all of our practice facilitation, we say we would like you to meet with the practice for about an hour per month, but it is up to the practice. And so we track both what they do when they meet at this discrete level, and we track how much time. And then 1 hour per month is a minimum. So if they want more, we give them more. So that goes into like some dose response kind of stuff. But yeah, you're totally right that in almost all these situations, we're still treating it as an ITT. So it's really like, you've been offered this, here's what we hope you do. But yeah, it's, you know, what happens is tracked very carefully and then incorporated, but it's not mandated, or, you know, unless you have resource constraints, it's not like cut off that you can't get more than like a couple hours or something.
Another version of that in terms of control, Jonathan, like I have a type 3 trial where an learning collaborative plus training is one study condition and just training is the other, right? And so the learning collaborative is our implementation strategy. We have a specific hypothesis that communities who have both will achieve better outcomes and sustain the program compared to those who get the digital training only. So we're testing that. So we're randomizing communities to one of those 2 conditions. Does that make sense? So we have very clear control in that situation, but we're testing that implementation strategy. So that's kind of the control in that setting, right? Like that, we have a very clear hypothesis about what we think it'll do.
Indicators or metrics of what you're testing and evaluating changed if you do a discrete strategy versus bundle, and can you give some examples just for?
I don't know that it changes, to be honest. I mean, they're both your independent variable. They're both like your exposure, essentially. You should pick variables, outcome variables that are as relevant as possible to the strategy. So, Paul uses this language, and I know a lot of the reading people do too. When they talk about strategies, they actually label them as what they're trying to achieve. So they'll say these are reach strategies, these are sustainment strategies. So in that case, yes, but it doesn't really matter if your sustainment strategy is a bundled strategy versus a discrete. It's still likely to show an effect on sustainment. If that makes sense.
Yeah.
Ashley, did you have a question? No. Okay. Other questions on strategies?
This will be the topic of the entire,
It could be an entire workshop. Yes.
There's also too, like, for people who are newer and look at Eric for the first time, I don't know, they call it discrete, but I struggle with Eric because I see they're not mutually exclusive things. They're like
Yeah.
same things using different terms. So that session will be helpful.
Yeah, and I think that's one of the hard things with implementation strategies is we often want to simplify them into a yes, no, or a delivered, not delivered. But it can be messier than that, certainly when that is maybe not that different than one element of your intervention itself, right? And so really thinking that through and being clear on it, kind of what that line is the thought work you kind of have to do, kind of going into this. Okay, you're up next. IRLM. Yeah, we're
Okay,
ready to.
so now we're going to try to put the pieces together in a somewhat coherent fashion. So we have not gone into like great depth in any of the like key elements of implementation research, but hopefully it's starting to feel like at least you can see some of the relationship between the key elements. The IRLM is specifically designed to help do this in a traditional kind of logic model format. I already can see in my preview that my animations are off. Whatever. So ignore, this is supposed to be blank. So the IRLM starts with defining what is your thing, right? What are you going to implement? The reason this box is not just one line, because you can't just say like an intervention I work with is called family checkup for health. I just can't say family checkup for health and be able to know what that means. So I would actually put in family checkup for health, and I would put the key components of the intervention that need to be implemented, okay? That can be lots of different things, of course. Just think of your own intervention. What would you actually have to say? Like all these things have to happen, right? Even in very simple interventions, like let's go back to hand washing. I mean, everyone knows like the challenge of even just getting healthcare professionals to wash their hands to reduce, infection within hospitals. Hand washing itself sounds so simple, right? There's a lot of things that have to happen to make hand washing frequently actually happen. And all those things should be broken down so it's very clear. Okay, the left hand, or sorry, here's our 7 Ps, just as an example of kind of what would go in that box. The process of completing the IRLM typically is done through what I've called bookending, which essentially is either starting on the left or the right, and then doing both those first, and then filling in the middle. And you'll see why that's the case when we start thinking about the logic of how we do implementation research. So oftentimes, if you start on the left, it's because you really understand your context, okay? I know exactly where I'm going to deliver. I know the context for this, the fit of this intervention with this context. And this is actually here to show that you're supposed to plug in a context framework, right? Use CFR, use EPIS. This is the I Am for Equity framework that James and I are part of the development team. But use something, social ecological, whatever you like, doesn't matter. Just some way of organizing and applying a framework into that side. We then often go, okay, so again, I'm going to go back to the underlying theory of implementation research. One of our big things is that your clinical health intervention should be aligned with and have some fit with your context. It should be something they want, it should be something that's going to address the problems they have. And you're picking something when there's multiple options that is the best fit, okay? I'm going to actually go forward all the way and show you. So on the far right, you have the outcomes. if you remember back to the implementation outcome framework, that is actually an IOF on its side, right? So it's basically saying that implementation outcomes precede the downstream clinical benefits that are realized through an effective implementation. And you can see the arrows too. So we have the two arrows that are pointing from context, meaning there's an alignment of context with the intervention. There's an alignment of the strategies that we select with the barriers, facilitators, and determinants in the context we're working with. And then if our strategies work, they work through mechanisms that look like little gears, because I don't have a mechanisms framework to put in there yet. And the first thing that they impact, and that's the blue arrow on the top right, are implementation outcomes. Okay, so we're still interested again in this whole downstream effect. And there is a sort of lightened, more transparent blue arrow at the bottom that is meant to show that, yes, the direct effect of the health intervention that you're implementing are patient level or client outcomes. But the totality of the system is really what we're interested in for implementation research and understanding if our implementation strategies actually worked. Any questions about the IRLM? This is also the topic of like a full workshop if we wanted it to be, but again, just really trying to like put the key pieces together and how they're supposed to logically fit in the context of a complex study.
What do you mean by determinants?
So determinants is just it's a term that's used that I don't love for contextual factors. And then barriers and facilitators are contextual factors that have a valence, right? You're talking about how they function. So financing could be a barrier in some situations. It could be a facilitator in others. So financing itself is a determinant or a context variable. Saying it's a barrier facilitator is getting more specific about how it's going to impact your implementation. Yeah.
To this, like you mentioned, implementation outcomes kind of come before like outcomes, but
Just conceptually. Yeah. That is one thing that's a drawback of most logic models is that there is no specific time-based component to this. We have some examples of people who have shown they've actually put strategies according to the EPIS phases. So they'll say the strategies we're using during exploration are X. The ones we're going to use during the preparation phase of implementation are these strategies. Once we start implementing, these are the strategies we'll use. So there are ways to build in some actual like real time-based components to the logic model about how your project is actually going to unfold. But in terms of actual like temporality here, you will see, or you can collect often implementation outcomes that well precede your actual client outcomes. So thinking about a preventive intervention that takes a year before you actually would want to say like, yes, the intervention was effective. It prevented a new HIV infection over a year. You're going to be able to know, did the intervention get delivered? How many sessions did they get, et cetera, well before you actually have the endpoint outcome. So there is a little bit of that, but it's mostly conceptual. Okay, let me show you a couple examples too. So there's the IRLM can be used for several purposes. It's been most commonly, I think, used in the planning phase. So essentially when you're working with your community partners, your implementation partners, your stakeholders, whatever you want to call these folks, but the individuals who are going to be actually involved in adopting, delivering, or benefiting from the intervention, completing the logic model with them and with data that you gather from them. Yeah, and so you can do this really mostly for the context factors and the implementation strategies. But again, I think having your partners help you define and prioritize the implementation outcomes and the clinical outcomes can be really beneficial too, of course. There's many examples that are cited. These are just ones that I was an author on. For executing, this is the phase of essentially like when you are implementing, you can use the IRLM essentially as your protocol. And you can also use it to help actually track how things change over time. So having multiple versions of your logic model, it can be really helpful actually showing sort of the process of how implementation occurred, what strategies were potentially like discontinued, what strategies did you not think of but actually needed and you had to add as you like started implementing. Happens almost in every study that I've been part of, that those kind of changes happen. So it can actually serve as a way to track those things. Some folks have actually used it as well for reporting the results of studies, okay? So actually just being a figure to say, here's all the stuff that we like learned in this project. Here was the primary, barriers that we encountered. Here were facilitators that we saw were really important. Here's the strategies that actually were used and worked. And here's some of the outcomes that we achieved. So really effective basically as a single figure for that. And then the last thing that it's been used for, and James is working on this right now with us, and I have a couple other folks who are doing similar things, is really using the IRLM to synthesize across multiple projects. So again, like there's situations where that Nelson et al. Paper that cited there was a systematic review of implementation research for a specific intervention in a specific context. They used the IRLM for the reporting of the synthesis of all the findings. So they basically were like, here's all the common strategies people used, here's the common barriers everyone had, and here's the outcomes that were able to be achieved from it. This other paper with the author name that I will butcher, so I'm not going to try it, is a multiple case study approach. So they actually intentionally had 3 hospitals try to implement the same intervention, and they used the IRLM to create first 3 IRLMs, 1 for each hospital, and then they presented in this paper a combined synthesized version to say, hey, if any other hospitals are interested in implementing this thing, here's a place to start. Okay, so pretty cool uses of it. Yeah, we're doing some work on it right now too. So here's some examples, and I want to disclaimer this as well. What you'll see here are examples that took 15 to like 30 hours of actual work to complete. And that does not include the actual like primary data collection for the data that was used to populate this. So it is an involved process to get to a comprehensive IRLM, but hopefully you can see like how much detail actually gets presented in this. So this example is a healthy weight clinic implemented in federally qualified health centers as part of a CORD 3.0 study that I'm part of. For this, here's the components of the healthy weight clinic. So this was the multi-component intervention that had been previously shown to be effective, and now we're trying to figure out how to actually do it in federally qualified health centers. And this, it was in 3 states that we were working in. I got a little wonky. But in this particular case, we started with the outcomes. We knew what we were trying to achieve, and so that was the place that we started with our logic model. Couple things that are kind of unique about this one that I'll point out. Actually, I think I'm going to come back to them. The next thing we did was determinants. So we worked with our community partners to both do qualitative interviews and to do some other kinds of data collection. Some of it was observational, some of it was going to the literature, but really to try to figure this out, we populated with CFR. So you can see this is the process characteristics, et cetera, of the CFR framework. And then I'll come back to some of this notation. We then picked the implementation strategies, really focusing on those 2 arrows of combining what does the healthy weight clinic need? What are each of those components? What strategies are needed for each component? And then how do those align with the barriers we're going to have to try to address and overcome? We then proposed some mechanisms for how the primary strategies would actually work. So some things I want to point out, these are typical notations, but they're not required for the IRLM. For doing the Cosmos linking that we talked about before, we often use superscripts. So we start with the implementation strategy as essentially all of our A, B, C, D, all the way down to L, I guess, in this case. What we then do is we say, okay, going backwards, what determinants is this associated with, right? So training modules are for a specific purpose. They are trying to address the complexity of the intervention that you can see there for complexity. It's also trying to address here for characteristics of individuals, their knowledge and beliefs about the intervention. And training is needed. So that was another piece. So what that happens, it goes through all the way to the outcomes, right? You can see that each of these things, my red got messed up on the outcome side. But essentially we thought that if we could, that our training modules would increase knowledge and skill for clinic staff to address some of these issues I pointed out. And that if it works, we'll see it in increased ratings of acceptability and feasibility of the intervention after training. This particular case also has primary outcome. Oh, yeah. Also has primary outcome. These are fun and totally messed up. We also sometimes include primary outcome. So this is this was a pilot study, so non-randomized. And we had 2 phases. In the early phase, trying to get to adoption, like even pre-adoption, we were looking at acceptability and feasibility. Like, can we actually just improve their perception of this program as being feasible and acceptable for their setting? And then in the actual implementation part of the project, adoption itself was the primary outcome. Like, did they actually adopt? So we had sort of a 2-phase, and an outcome for each phase. Here's another fully completed logic model. This one actually includes elements of the research design. So same thing again, we had our superscripting down the center there for the implementation strategies that are connected to our determinants, then our mechanisms and outcomes. Our determinants here, we have multi-sector this is faith-based organizations and community health centers. So in some cases, you can see like there are intersetting for both the FBOs and the CHCs. There are also the implementers in those two different contexts because they have different barriers facilitators. So you can see like really complex studies, you can show a lot of information about what's going on with just the IRLM. The other place when I mentioned the study design, this is a practice facilitation study. So this is a cluster randomized study where half of our community health centers will be randomized to receive practice facilitation. The others will not get practice facilitation, but across all arms, you can see the blue strategies we call core strategies. All CHCs get those. Okay, so we're isolating the effect of practice facilitation. We are not saying you get practice facilitation plus all this other support, and then the other arm gets nothing, right? Because then we're not able to isolate, well, what did practice facilitation do? The other part that's unique about this one that's probably not relevant to go into too much today is if you are testing a multi-level intervention, that by its very nature actually includes both strategies and healthcare interventions or health intervention components. This is a little depiction of how you can show these are the strategies, but they're part of a bundle. We have to implement the entire bundle. The strategies above are actually to help us implement the full bundle, not just specific components. So you can start to see like the multi-level nature of this. It can get complex, but this was, again, a lot of information shown in a single picture. I do have some terrible animations probably here too. Yeah, there you go. Look, fun. Any questions about the IRLM? Diana, yeah.
Caught my mind, caught my eye for it, but you have determinants and mechanisms. For example, trust, it seems like it's both a determinant and a mechanism.
Yeah, so a mechanism often is actually modifying a barrier facilitator. So you'll see similar terms used in the mechanism that you do sometimes in determinants. That's not true for every mechanism, but a lot of them are like that. James.
Yeah, in the first image you showed that if there's not like a good taxonomy for mechanisms, is that in the works? Are there people that are kind of working on coming up with multi-level mechanisms that can easily be kind of ripped through and used to?
I think so. There's a couple of grants that have been funded on mechanisms. I don't know if a taxonomy specifically is one of the products they're working towards, but I think that we will get a lot of information from those two studies that could help us really figure out this mechanism box. Because right now it is sort of it's a black box.
People are just saying whatever they think is the mechanism.
Yeah.
When I talk about it, I want to get back to it. It's like it seems like you made up this mechanism.
Yeah.
Like, how do you know that that's actually how it works?
Sure.
How do you empirically test that?
So that's a different question too, is a lot of time, are you going to test the or test the mechanisms, or are these just hypothesized? And you can see here, we are not measuring, actually we are measuring a couple of these, but none of these, we've labeled it as hypothesized specifically because none of these have been shown to be mechanisms at this point. So we are testing them. We are going to measure these things. But these are not things that have been previously shown in the literature to be a mechanism of this specific implementation strategy. Okay, so if you want to use the IRLM, we do have a really great interactive web-based IRLM tool. It's free. It's available at hivmsci.northwestern. It is not specific to HIV, even though that is the group that we developed this with. So it can be used for anything. Okay. The last thing we want to do today is talk about how do you conceptualize implementation research questions. And that's going to be our final little small group, is actually trying to get a couple on paper for each small group, okay? So this is a thought process essentially of how we went through and justified a proposal for actually the first large federal grant that I had on implementation research back in 2015, I think is when we submitted this. So essentially, these are kind of the arguments that we laid out in our significance leading up to our question and then our aims, of course. So this was the premise essentially, or the context, is that family-based interventions for pediatric obesity are effective. There are many programs across the board. There's a USPSTF task force. There are multiple systematic reviews and meta-analyses that say FBIs, or family-based interventions, are effective at reducing pediatric obesity risk. So that's the thing. Okay, we know what that is. So despite policies and payment models, including a USPSTF B rating, which means you can get reimbursement for delivering family-based interventions for obesity, and a high demonstrated need. We probably all know that pediatric obesity rates are on the rise across all age groups in the US. Pediatric obesity interventions are not widely implemented. So we have evidence of that from the literature too, is that there are very few places that actually do this. Okay, so this is basically the situation of an evidence-based intervention is available, people have not adopted it. So we also have a need to identify the service delivery system. Okay, so you can deliver family-based weight management interventions in lots of different places. Jenny's work is in community-based organizations and outside of clinics. My work is commonly in clinics or in coordination with primary care clinics for basically the same intervention. So the ideal service delivery system, we said in this grant anyway, for implementation for pediatric primary care. We said basically that, drawing on evidence that 96% of children under 10 years have a regular well-child visit. So we're going to catch the majority of kids who potentially have obesity or risk for obesity if we can identify them and intervene through primary care. You could do this in schools, but think about kids who are under school age. You're missing them. So 2 to 5-year-olds kind of out, right? But primary care catches them all. The other thing that we noticed, and this was data that we actually collected as preliminary data for this study, we were able to say that obesity and parenting are very common topics in primary care. And those two things are less stigmatizing, or parents experience less stigma talking to a primary care doctor about their kids' obesity and their own parenting practices than if they did it in like the school. Okay, so think about as a parent getting called into the school and the teacher wanting to talk to you about parenting. Probably not what you were expecting. Probably not the source you really want that information from, but pediatricians are often like one of the most trusted sources for that kind of information. So it's likely to be highly acceptable for parents to receive this type of intervention in primary care or through primary care, okay? So that's our justification for the delivery system we approached. But then when we have our delivery system, we have our thing, we have to start looking at what are the potential barriers. So in primary care, there's a lack of a trained workforce, lack of space for behavioral interventions in most clinics. These are not brief interventions, so they can't be done like in a typical well-child visit. Most interventions only address obesity, so parenting and child behavioral issues that are often co-occurring, that are also the two other most commonly presenting problems, typically get referred. So then the parents are actually engaging in multiple programs with multiple service systems, multiple providers. You can just see like this is potential chaos, especially for families that experience lots of health-related social needs. So that's our implementation gap, right? So why is this thing that is available not already being adopted and implemented? We've established the gap, the need, et cetera. So here's our research question. This is general. Of course, we have this project had 4 specific aims. But our research question that we posed was, can an evidence-based family intervention adapted for pediatric obesity and delivery in primary care be effective and implementable? What strategies are needed? What is the cost? Can existing behavioral health staff and federally qualified health centers be trained to deliver with fidelity? Those are all almost perfectly aligned with the aims of the study. So aim 1 was adapt the intervention. Aim 2 was deliver it through primary care and using strategies that are related to training existing staff and also tracking the cost of implementation. So you can see like how this is, all this different information is sort of needed to make the case or to build your own research question. So everybody who does practice change or thinking about doing an implementation project can probably think of a similar logical story to make the case about why you should do this work. Let me give you a very basic, and this is also a synthetic, not real example that I came up with years ago and keep using because it seems to work. But this is the premise is basically that an urban primary healthcare system with 54 clinics in a high HIV prevalence urban area wants to increase the uptake of pre-exposure prophylaxis by 50%. For folks who don't know what PrEP is, it's essentially, it's multiple forms now, but it used to be a 1-a-day pill. Now you can do it as an injectable. That is for folks who are HIV negative, but indications are that you have sex with men, so men who have sex with men, transgender, sex workers. Some of those folks are at the highest risk for new HIV infection or indicated to take PrEP. Okay, so if you're wanting to reduce new infections in your jurisdiction or your clinic, PrEP is a great way to do this. So you can tell even by the premise that PrEP is already eligible to be delivered. They want to increase it by 50%. They don't want to increase it to 50%. So leaders in the health system decided to compare whether referring potentially eligible patients to a specialty STI HIV clinic, which is really common, like a Ryan White clinic or something like that, for PrEP, or providing PrEP in their clinics by their clinicians. Okay, so what kind of things can you already think about here in terms of context strategies and outcomes that we might be interested in to formulate a research question just based on this premise. Go ahead, James.
Well, we want to know if the clinicians have some type of ability to adopt.
Okay. Yep.
And also, folks that are going to be coming to the, if that's an acceptable setting to receive that type of
Okay.
care stigma that might go with coming to a primary care clinic to talk about.
Okay, so 3 potential outcomes are adoption by clinicians, the actual reach to the patients that they see who are eligible, and then whether or not getting PrEP at a primary care clinic is acceptable to patients, and potentially even to the clinicians, right? Do I actually feel that it's acceptable for me to be prescribing PrEP as a primary care doc? Dana.
Cost, right? So
Yep, question about cost.
they're in your clinic or through referral service.
Yep. Yep. So is it cost effective? Or in this case, maybe is there actually an ROI? Because you can bill for actually the prescribing of PrEP. So basically, what's the economic case for this? What else? Anything else you can think of? What about strategies? Okay, changing workflow might be a strategy that's necessary. Yep. Yep.
Reminders, so reminding.
Building in reminders about it. Yep. Different strategies, okay.
Guideline for how that.
Training on the guideline. Yep, there's a CDC guideline out for PrEP. What about even more high level than that, right? So the question itself is inherently, is referral to an STI clinic better than in-house? That in and of itself is a strategy, right? And then there's all these specific strategies for each arm that you'd have to do. So those are kind of our big things. So let me actually go to the research question that I came up with for this. So the question was, does training providers, so there's our training primary care physicians to identify and prescribe PrEP as part of routine preventive care lead to provider adoption and to reaching more eligible patients compared to referring them to specialty STI HIV clinics? Okay, let's break it down even further. Here's our implementation outcomes. Or sorry, here's our strategies: training and identifying and prescribing PrEP as part of routine care. So in this case too, this particular identify and prescribe as part of routine care is one strategy in a comparison-based trial. Okay. Training is an example of an educate strategy. Basically trying to integrate into routine care is probably a restructuring strategy, broadly speaking, but it probably requires workflow change and some other things as well. So the next thing is our implementation outcomes. We have provider adoption and reach, just like James said. Other implementation outcomes that might be of interest, we talked about acceptability to both of them. I sort of alluded earlier that this is one example where the question of appropriateness is actually really critical here too. One of the things like 10 to 15 years ago when PrEP was first starting to get pushed out into real world care is actually talking to the potential recipients of PrEP. Where do you want to get this? And a lot of them said, I'd rather go to an STI HIV clinic because they're used to dealing with people who have high risk sexual behaviors. It's less stigmatizing. I don't want to talk to my primary care provider about my sexual habits. So that's a question of appropriateness, not a question of acceptability. Acceptability of PrEP is probably pretty high among people who could benefit from it, but appropriateness is where should I get this and who should I get it from? Okay, and then again, I sort of already mentioned that this is a question that sets the stage for a comparison-based trial where you test prescribing as part of routine care versus the referral-based model. So this is almost like a model of care as a strategy. But then again, with multiple discrete strategies within each one to make it actually happen. So here's what the specific aims might look like. So one of our aims could be train primary care physicians to identify and prescribe as part of the part of routine care following current CDC guidelines. So training in the guidelines probably going to have to be part of your strategy. Aim to increase primary care clinicians' adoption. There's our adoption metric. Test 2 strategies for reaching PrEP eligible patients. So essentially the healthcare system said, we want to increase reach by 50%. That should be our primary outcome. So adoption is necessary to get high reach, but of course, we'd want to power on the thing that is the primary interest outcome. So some specific questions that we could ask here are, which strategy is more better? Okay. I think it was more effective, and I was like, I don't want effectiveness in there. Okay, so which strategy is more better at supporting providers and patients to start eligible people on PrEP? Reach, adoption, acceptability were the three kind of things that are related to that question. Another question is, what are the contextual factors that are barriers or facilitators to getting eligible people onto PrEP, and how do they differ between the two strategies, right? So the two different models are going to have different barriers. What if I have to establish care at a new place at the HIV STI clinic? That's a barrier potentially. What if my insurance will cover it as part of routine care, but it won't cover going to a specialist? So different, kind of different issues with each of the different arms of the study. Yeah, question.
So if you go back to, the other big slide, or actually it's greatly before, you don't need to go back. So it said leaders decided.
Yep.
So would you say the question, if the question about the difference between leaders deciding and whether or not they even considered the clinician perspective and their preparedness to uptake this new idea, like, is that a separate research question, or is that something that you study under adoption?
So yeah, that's a good question. So in a situation of sort of top-down leadership decision to make change, yes, that is going into sort of understanding the adoption rate that you get, right? So when in a re-aim framework sort of perspective of adoption, you're measuring the number of people adopt and the number of providers who adopt, the proportion of providers who adopt, and then representativeness. And then you also try to understand factors that are related to adoption versus non-adoption. So it would sort of be like a sub question under this like primary question about adoption. Yeah. So other implementation outcome metrics, so this is actually just breaking it down. We touched on all of these already, except for feasibility. So the primary ones, which are sort of, again, these are the actual data-driven ones, or actual like service data-driven ones, are adoption. So providers prescribing PrEP. That was our definition of adoption here. If you provide PrEP, you were considered an adopter. As a reach metric, it is the proportion of eligible patients who get prescribed. So in both arms, we can look at who actually got a prescription. This doesn't mean they took it. That's a whole different potential question, is why are people not taking PrEP that they get prescribed? But when we're trying to change practice, we're trying to change the delivery. And so we actually wanted to say, are you actually even just prescribing? Okay, we can look at, actual uptake and use in a different way, but this was really about the provider behavior. Acceptability, we want the provider's perspective. Is it acceptable to them within the primary care practice? Appropriateness, provider and patient perspective. You'd be surprised at how many primary care docs are like, I don't want to learn how to do this. I'm not appropriately trained. I'd rather send them to a specialist. Okay. So you might have some resistance to adoption based on that perspective. Feasibility, does it increase time with patients? Does it increase wait times in the clinic? Does it actually reduce the number of total patients seen, right? All those things are considerations, especially at the operations level. And again, probably contribute a little bit to the question of cost too. Is PrEP provision in the clinic cost beneficial or cost neutral for revenue, as well as the effects that have been achieved, right? So it may actually be that you reach, more people, but it costs you so much that it's not worth it. And you'll just, a system may decide we're just going to stay with referring. So here's what the logic model might look like for this. This is a very simple version, but you can kind of see that within CFR, some of the kind of primary things, they're color coded for following through in a second here, but essentially we did, the CDC guidelines, having well-established guidelines, that's a facilitator. So we put a plus there. A couple of the negative things is we thought stigma, as James mentioned, might be a concern, might be a consideration that would be a barrier to this. Knowledge and beliefs and attitudes about PrEP. There's a lot of negative stereotypes that lead into stigma, but a lot of it is actually just misunderstandings of what PrEP is for and who's eligible. So you can start to see all the different levels at which we have different barriers, facilitators. We picked 3 kind of primary buckets of implementation strategies. So one was training providers and staff about these different topics. Integration into routine care, so doing a workflow evaluation, potentially incorporating continuous quality improvement or PDSA cycles, and then also doing peer support and engaging leadership in these decisions as well. So having peer support champions essentially in this one. We hypothesized like some mechanisms through which these would work if they do. And then those are obviously related to specific implementation outcomes. And you can see that adoption, reach, appropriate acceptability, feasibility are all the kind of primary ones there. The service outcomes, we wanted to make sure that there's consideration of safety, that the practice is patient-centered, that it's delivered equitably, we're not leaving out particular people who are eligible for PrEP, and that it's also timely. So the issue of someone who's high risk for new HIV infection, we want to make sure that we are more timely getting them prescription. So that could actually be another outcome, is the time to receiving a prescription shorter, or even filling a prescription shorter if you do it in-house versus referring? We could probably hypothesize what's going to go on there, but regardless. And then, of course, we have multiple metrics that we could look at for our patient level outcomes. One of which, I think the one that's the most important is the primary at the bottom there with the asterisk, which is we want to prevent new HIV infections, right? That's the ultimate goal of prescribing PrEP. But we can also look at all these other things too that are relevant. Okay, any questions before we have like very little time for a small group, but we're going to do it anyway. I talk too much. Any questions before we jump into a small group? And the small group is basically formulate 1 or 2 implementation research questions that kind of look like the one that I just gave as an example. Okay, so let's do that. Let's just break into a group. We're going to do like pretty quick so we can actually do a report back. So yeah, try to formulate 1 implementation research question that's in your area of research, your clinical practice. If it has the word effectiveness in it or patient health outcomes, I'm going to come around with my ruler and like, school marm you. Get as specific as you can. Try to actually include like what's the outcome, what are some potential strategies, and any indication of what kind of a trial design you might have, whether it's comparison based, factorial, compared to usual care, observational, like any of that kind of stuff. All right. Oh, question. Yeah. Oh, like the premise slide? Yeah. Do you want to just leave it up? Sure. Okay, cool. Let's take about 5-6 minutes and then we'll come back and a couple groups can share. All right, everybody. Just our little time check here. We're going to come back together. Oh, breakout rooms. Okay, so as we're wrapping up and coming back, we're not going to have time to do an actual report back on our research questions, but happy to talk to anybody over lunch who's staying for lunch. So I just wanted to end today with just a little bit of information about some implementation science resources at the U. So as we mentioned before, Jenny and I are part of the Dissemination Implementation Science Corps, as is Toby, Liz, and James here, and a couple other folks. Our overall is really to help speed research discovery. I mean, it's the same aim as implementation science in general. We provide consultation to teams at the U in the use of theories, models, and frameworks, measurement and evaluation of implementation process and outcomes, implementation strategy selection, tailoring, and tracking, and of course, study and trial design, as well as analysis. Everybody who's here, if you're part of the U, if you're developing a proposal, we offer 20 hours of free consultation, after which time there is a charge, a core recharge. And people build us into grant proposals both as a core service or as investigators, depending on how much IS you need. But yeah, you can request a consult through the Triad Disc core website or emailing Liz or I. We take those via email too. There also is a graduate certificate in implementation science. This is the 2nd year that it's been offered. It requires 15 total credits. The required courses currently are a Intro to Implementation Science and Dissemination that Jenny and Chelsea Schlechter co-teach. I teach the Advanced Implementation Science Methods in the spring. Health Systems in QI was offered last year, not this year, but it's one of the required courses. There is also a 1-credit seminar series in Dissemination Implementation Science that we suggest you take after you take the introduction course. And then there's also a potential course that Paul is developing that'll be community engaged dissemination implementation science that will be not required, but it'll be either that or the health systems and QI course as your other required 3-credit. So 15 total. The others would be things like cost effectiveness, trial design, community engagement methods, some other things that you can take that are graduate level courses. We also have a thing called MS-SETI, which is the Mountain States Partnership for Community Engaged Dissemination Implementation Science. We go to cool places. That was Albuquerque this last August. The year before that, we were in Flagstaff, Arizona. The year before that, we were in Midway here in Utah. It's fantastic. Ton of fun. ASU, University of New Mexico, Salt Lake VA, Phoenix VA, us. Pyre, a whole bunch of institutions are providing resources and support for this application. It is a year-long training program. for early career scientists geared towards submitting a D&I grant proposal specifically. And then as we're kind of wrapping up, we have a quick evaluation. We'd love to get some feedback. We are also happy to take suggestions on topics of future workshops and little, mini offerings that we could possibly do. Again, we do have the other two in January and April already scheduled, but if there is a desire for a talk on strategies, a talk on study designs, we could figure out a way to offer another one, or to just put those in next year's offering. So we'd love to hear your feedback about things that would be helpful for you.